Very good afternoon to everyone. So this is way back from 2005 when I was doing my first ICL, I think. And in the first 2 or 3 of them, I realized that you can't do wound-assisted injection. That time there was nobody to teach us, and we were learning all these things ourselves. And we were, all doing wound-assisted injections. So here I was in a situation I didn't know how to deal with it. Eventually, I did manage to, kind of get it out over there. But then over time, we've learned that this is not how you do it. And today, first thing is never do wound-assisted injection. Try to get the nozzle of the tip of your cartridge. But sometimes, if it does happen, especially if you're doing under topical anesthesia and there is a movement, sometimes you will still end up having a ICL. The easiest thing is to just pull it out and just hold it with an ICL holding forceps. And if the ICL is stuck inside, you'll just pull it out and it'll just come out very easily, just like you're explanting an ICL. So it doesn't kind of look very difficult. And never flip the ICL inside. I've done that once 20 or 15 years back. And again, I used to think that, when you can do it with a cataract surgery, why can't you do it with the ICL? And I filled up with viscoelastic. I managed to get away. I mean, there was nothing that went wrong with the cornea or with the lens, but, it's like totally crazy to do it. So easiest thing is to just hold it and pull it out and not really try any manipulations. So going on, now we use a lot of Indian ICLs also. So I've been using all the 2-3 currently available Indian ICLs, and they have a different injector system from the STAR system. And sometimes you will have a situation where you're using this kind of an injector, and as you inject, sometimes it'll catch hold of one of the haptics or the ears of the phakic lens, and it'll get stuck in the injector system. Now, to avoid this, best thing is that when you're pushing it in the cartridge, just keep withdrawing a couple of times. That way it doesn't catch the haptic. But if it does, then the best way is, of course, to just again try to manipulate like this, that you kind of retract the plunger and then push it a little bit and then retract again till it becomes loose. Otherwise, it will break and you won't have a well-centered ICL. So this again is something that one must do. And another situation where sometimes if you have a big incision for the ICL, as you would normally want, like at least a 3.2 or something is what you should do, 2.8 to 3.2. You may have a leaky wound occasionally, and then you can just make a supraincisional. You don't want to suture these wounds because you'll induce astigmatism, and this is a refractive surgery. So you just go in there and make a small supraincisional pocket and then hydrate it. I think this video is kind of repeating itself for some reason. So anyway, I've made that pocket. I'm going to hydrate it. And once you hydrate this, it just stops leaking. You can keep struggling otherwise. And so here, then you do the trypan blue test and you don't need to suture these. Again, if you get very high vaults like this, 1.39 millimeters, which is quite crazy, you can get lots of complications, even though the centraflow now, does not give rise to many complications which we used to get in the past. But you can still get it, and if you get a very low vault like this, you may still have other possibilities of complications with cataract formation, again, which is extremely rare now with the centraflow. Yet, you may also get sometimes decentered ICLs, again, if the vault is low or if sometimes there's some zonular issues, especially if you have a lax zonular support. So these are some things which need to be tackled. And in the past, as you see, this is a non-centraflow lens. A lot of patients are coming in now whom we had operated with ICL more than 10, 15 years back. Some of them are coming with these cataracts because their vault has gone down. So an ICL vault typically goes down by about 15 to 20 microns per annum. And over time, you may have a very low vault. So if you have a centraflow ICL, it may not induce anything. But if you have a non-centraflow ICL, as was done in the past, you may end up with a cataract. So this was a very interesting case which was referred to me. A patient came to me saying that, I've had ICL in both eyes. One eye is doing extremely well and the other eye he was not seeing well. So I noticed and I thought there was a hazy cornea also, and I saw an upside down ICL. Now, if you don't see the vault very carefully next day and you can't appreciate it, ideal thing is, of course, to do OCT routinely to measure the vault, because that's protocol at our center for almost 10, 15 years. But if you can easily see this on the slit lamp, you can't leave an ICL like that, and you have to actually get it out. So for this patient, it was a bad situation. I referred him back to the surgeon, and the ICL was removed, but patient went on to develop a very bad cataract because it was almost 2 weeks after that ICL had been implanted, and we eventually had a tough time getting this ICL out because there was all capsular fibrosis. There was in fact a small hole in the entire capsule right in the middle there, and there was some cortex which had already got absorbed by the time I got to operate this patient. But anyway, this was a lesson, and so we should always be very careful. I'll just skip this one. Okay, so this was a lady who was coming to us for almost 5 years and very keen for refractive surgery, very high astigmatism on oblique axis with a stable refraction. And case were like 47 and 50 and 46 and 48. She had a keratoconus in the eye, and she was very keen, and with stable refractions we decided to go ahead with a toric ICL. She improved with refraction to 6.9. So toric ICLs have to be very carefully used in keratoconus eyes. Unless you are getting excellent refraction and good stability, you can't use a toric ICL. So this patient, we had a situation because the white to white was sitting right in the middle of two sizes of the ICL. So on the first visit when we measured, we were getting a white to white which was 0.1 millimeters different from what we got later on manually. So we had already ordered a 13.2 lens based on the OCOS. On subsequent visit, like she was diabetic, she was controlled over, she's 35-year-old girl. And we managed to control the diabetes over a few months. And on the second visit, independently, one of our other consultants got an ICL size of 12.6. So now we were sitting with like two sizes of ICL, and we were not able to decide which one to use because the white to white was sitting inside both. So this was a unique case which probably doesn't happen to you very often. We went ahead with the 13.2 because with keratoconus you have a very deep chamber and you have more room for surprises, because you may go in with you can end up getting a wrong size. I'm sorry, we went ahead with the 12.6 because you don't want to get, in keratoconus you have a falsely high AC depth. So we went ahead with the implantation, and there you can see that the implantation was effortless. But once we had the ICL in place on the intraoperative OCT, we found that the vault was not to our liking. So we'll just see the vault over there on the side. So the vault is almost flat. This was a 12.6 size ICL. The vault was sitting almost flat over there, and luckily for once we had the 13.2 with us for the same par, because we had ordered that before and we also had the 12.6. So we went ahead with the ICL explantation and got this ICL out, and in the same sitting we could actually replace this ICL with a 13.2 ICL, where the vault then was much better. So this was the second implantation on the same sitting. So this goes to show that the intraoperative OCT can be a really useful tool, especially if you have a vault surprise, which you will never make out in another way. And once this ICL was through, you can see that the vault on the right side was looking much better. I'm sorry that I'm just running this video a little faster because I want to finish one more case. So this is an Indian ICL. Sometimes with these ICLs you will get an optic capture. Is my time up? Okay, I'll just wind up after this show. So sometimes with these ICLs, for some reason, I tend to get an optic capture post-op, especially if you have a high vault. So I managed to get this ICL in nicely, and at the end of the surgery, it was looking good. And sometimes if you have a slightly higher vault, you might want to put pilocarpine on table. Normally we don't nowadays. So in this situation, we managed to get a good surgery through for this patient, and on table, this is how it looked. But you can see that there's a small optic capture happening over here. So then you position the ICL, and while this patient's vault was just about 600 to 700, we kept getting an optic capture, which we managed on table quite nicely. And at the end of surgery, actually, it was well managed and looking good. But when we saw next day post-op, again, this patient was having these issues with the optic, getting caught. So this happens sometimes, and you have to sometimes maintain these patients on a small dose of, we put them on IOTIM plus with a small dose of pilocarpine. So with that, I think I'll stop, and I'll, these are few situations I thought I can share with you. Thank you so much.
Hello. Yeah. Thank you very much, Dr. Gaurav. I think it was amazing potpourri of all the challenges that one can see, and definitely I think as one does more and more of these surgeries, some of these situations are not really, let's say, very rare. They are always, one has to tackle them correctly. And thank you for sharing all your